Welcome to the ASG Video Tips Series. I'm Dr. Chris Thompson from Brigham and Women's Hospital, and I'm with one of our second-year GI fellows, Dr. Sai Pichamon-Girapino, and she's going to tell us about a patient that underwent a bariatric surgery that's no longer performed in the United States. However, we feel this is relevant because we still do see these patients.
Thank you, Dr. Thompson. Here we have a case of a 57-year-old lady who underwent an open vertical banded gastroplasty in 1985. Over the past 6 to 7 years, she's noted gradual weight regain and has been sent to us by her bariatric surgeon for further evaluation. To better understand her anatomy, the following upper endoscopy has been performed.
Here, we're passing through the gastroesophageal junction and are now in the pouch portion of the vertical banded gastroplasty, or VBG. As we can see, the pouch consists of the lesser curvature of the stomach, which is on the right side of the screen. The proximal greater curvature and the fundus, however, are not seen here, as these were previously stapled and separated from the VBG anatomy. On retroflexion within the pouch, we can see the cardia of the stomach. A careful examination is performed and no abnormality is seen within the pouch. Here is the outlet of the VBG, which is usually created using a non-adjustable band. Now we enter into the remaining part of the stomach. The distal body and the incisora are seen. On retroflexion, we can see the inferior portion of the outlet. The distal stomach remains intact with a normal antrum. And going through the pylorus, we see a normal duodenum.
The vertical banded gastroplasty, also known as the VBG and commonly referred to as stomach stapling, is a restrictive gastric operation first described by Dr. Edward Mason at the University of Iowa in 1980. The procedure uses a combination of staples and a non-adjustable gastric band or mesh. The stomach is stapled vertically to create a small 20 cc pouch along the lesser curvature, and at the bottom of this pouch, the ring or mesh is used to create a 1 centimeter outlet. The Swedish Obese Subjects Trial, or SOS trial, included the VBG, as well as adjustable gastric band and Roux-en-Y gastric bypass. This was a large prospective study that was not controlled, and they showed that the VBG had an 18% total body weight loss at 15 years. Now, this is a good deal more than adjustable gastric banding, but substantially less than Roux-en-Y gastric bypass. Patients who have a VBG tend to lose most of their weight over the first year, and only 10% are able to maintain a 50% excess weight loss at 10 years. Additionally, long-term complications have been a problem for the procedure, and these include obstruction, staple line breakdown, band erosions, and weight regain. As such, this procedure is no longer offered in the United States.
Dr. Thompson, I'm just wondering, since VBG is no longer performed in the U.S., how often do you see these patients in your practice, and what do they usually present with?
So we may see one of these patients once every 3 or 6 months. So it's not terribly common, and they typically present to my clinic with weight regain, but they also may present with esophageal reflux or abdominal pain or something unrelated, such as irritable bowel syndrome. And when we're performing our endoscopic evaluation, we may look for a dilated pouch in weight regain patients, or perhaps a breakdown of the staple line with gastrogastric fistula, and that's also common in patients with esophageal reflux. Or in someone with pain, we want to look particularly for band erosion, because when that band starts eroding into the stomach, that is associated with a great deal of discomfort.
Thank you. So back to our patient. She presented with weight regain and had a relatively normal anatomy. What would you recommend to her?
So in patients with weight regain that have a substantial amount of weight regain, so they would qualify for bariatric surgery, we typically will refer them back to a bariatric surgeon for consideration of surgical revision, likely to a Roux-en-Y gastric bypass. And there have been a lot of patients that have undergone that procedure, and we understand it to be safe, but not without risk. Now, if a bariatric surgeon refers us the patient because they do not want to perform a surgical revision, we do discuss endoscopic options, and there's not a lot of literature to support this. We can close gastric fistula, and we can make the pouches smaller, so that is something that can be entertained. However, there's currently better evidence for surgical revision.
Thank you very much.
Thank you.